Good afternoon. I'm David Bartholomew from the American College of Healthcare Executives, and this is the North American session. For those of you joining virtually, you can ask your questions on the app, and we will be moderating those at the end of the session. Several of our attendees were not able to be here in person today, but we do have a video that we have recorded, and I do want to personally introduce two of our panelists for this, Dr. Melinda Estes, who is walking to the front of the room right now, from St. Luke's Hospital Health System in Missouri. Dr. Estes is the CEO of St. Luke's, and Carrie Owen-Pleats, who is the president for the Northern District of Kaiser Permanente. Carrie and Mindy, Dr. Estes, will be here at the end, and they'll come up on the stage at that time, and we will ask questions. For those of you that do not have the ability to use the app for your questions, we'll also be able to moderate them in person. And with that, I think we'll start the video. Thank you.
Good afternoon. I'm Rick Pollak, President and CEO of the American Hospital Association, and it's terrific to be with you today. I'm sorry that we couldn't be in person, but we've put together this hybrid approach to ensure that we have a valuable experience in sharing insights from North America when it comes to leading during times of crisis. And following this panel discussion, two of our participants will be on hand live in Barcelona for an interactive session to take your questions and comments. I want to thank the International Hospital Federation and our Spanish hosts for putting together this important meeting. And I'd also like to thank Ron Lavender for asking us to be a part of this program. You know, Ron has brought new energy, a spirit for innovation, and a passion and commitment to the mission and values of IHF. And there's no question that his leadership will enable the Federation to have a more significant impact. Speaking of leadership, I'm joined for this panel by three of the most capable and respected healthcare executives in the United States of America. In a few minutes, you'll hear from each one of them, but let me take a moment to introduce them. Dr. Mindy Estes is President and CEO of St. Luke's Health System, a 16-hospital system based in Kansas City, Missouri. As both a physician and a healthcare executive, she has been a medical professional for over 40 years, leading major health systems in the states of Florida and Ohio, as well as Vermont, before assuming her current position. Dr. Estes served as the chair of the American Hospital Association's Board of Trustees in 2020, which means that she was my boss. And needless to say, this was during the most challenging time in the history of America's hospitals, not to mention those across the globe. She has been and continues to be an incredible source of support and inspiration for our field, and her wisdom and leadership made a major contribution to our nation's ability to mount the battle against COVID-19. Carrie Owen-Pleats is chair of the American College of Healthcare Executives. She's also president of Kaiser Foundation Health Plan and Hospitals of Northern California, which provides care for more than 4.5 million individuals through its 21 hospitals, not to mention over 250 other care sites across Northern Calisfornia. She previously served in executive positions with other major health systems, most recently at the WellStar Health System in Atlanta, Georgia, and Sutter Health in Northern California. Carrie is recognized as a problem solver with a unique ability for bringing people together, which are key skills for a leader during times of crisis, and those skills have been put to good use during the fight against COVID-19. Her mantra, patients are at the center of everything we do. Words to remember in any discussion about healthcare. For the past 35 years, Michael Facina has served in several roles as a top executive of New York Presbyterian Health System. He is currently a senior vice president of the system, as well as president of New York Presbyterian Lawrence Hospital. Now, for those of you who are not familiar with NYP, as we refer to it, it has 10 hospitals and numerous care sites in the New York metropolitan area. And it's also home to two very prestigious academic medical centers, serving as the teaching hospitals for the schools of medicine of Columbia University and Cornell University. Michael is also the immediate past chair of the American College of Healthcare Executives, and we're going to talk more about who ACHE is in a moment. Michael has experience in leadership during a crisis, as NYP has been a key player in caring for so many patients and communities in the New York area during significant challenges, ranging from 9/11 to Superstorm Sandy to the battle against COVID-19. A couple of words here about the American Hospital Association in terms of who we are. Our vision is a society of healthy communities where all individuals reach their highest potential for health. And our mission is to advance the health of individuals and communities where we lead and represent those organizations that are accountable to their community and committed to health improvement. We're for coverage for all. We're for easier access to care. We are for better healthcare value. We want to see care provided in a coordinated, seamless manner. We want to focus on prevention and wellness. And we believe that patients, families, and other stakeholders are partners in what we do. As you can see, the scope of care here in the United States of America, 141 million emergency visits every year. Nearly 4 million babies are born annually. 29 million surgeries are performed on an annual basis, and more than 900 million outpatients are cared for. As we've gone through COVID, our strategy related to COVID really has been what we call the 3 R's. First was relief, both in the form of financial relief to our hospitals and health systems and regulatory waivers to cut through red tape and bureaucracy at the government level to allow us to act in a quick and decisive manner. The second R, recovery, reaching that balance between being ready for any emergency, spike, surge from COVID, but also being ready to return to regular operations to keep people healthy and serve their healthcare needs. This balance has been critical. And Dr. Estes led a task force of hospital leaders on pathways to recovery that has been very helpful in this regard. And then the third R is rebuilding. And that means, what do we reevaluate? What do we reboot? And what do we reimagine from this experience to build a better healthcare system for the future? And of course, the rebuilding part is what is really so significant. And as you can see from some of these slides, it takes a variety of different dimensions. There's that aspect of looking at the deficiencies in our own public health system, where in many ways our hospitals became the de facto public health system, and there are a series of improvements that need to be made. Some of the other lessons was an increased awareness with regard to healthcare disparities among vulnerable populations that need to be addressed, a greater awareness around the social determinants of health, a greater awareness for global trends, and a need to also look at our supply chain in a different way that is more diversified. We've learned a lot about hospital operations and the need to develop new care models and develop alternative sites of care, and to develop new staffing models to support those new sites of care. We've learned a lot with regard to the need to have our physical plant designed in a manner that is more adaptable and flexible. And then when it comes to the delivery system, we face challenges related to the financial implications of having to shut down non-emergent services for several months, and some of those being done on an episodic basis today. We've seen the need to be aware of taking care of COVID long haulers that have extended circumstances that require care because of having been afflicted by the infection. And then we have to deal with care deferred that now is in greater demand because of the reluctance of people to seek care during the height of the COVID experience. And there are a variety of different implications related to all of those dimensions. Last thing that we've come to realize is that we had 3 challenges before COVID, and those 3 challenges just became bigger challenges. The workforce, particularly around resiliency, behavioral health, that has emerged as a bigger issue than ever before, and health equity or disparities. That was an issue before COVID, and that just got more challenging. So with that overview, and before we get into our discussion, let me turn it over to Carrie. for a moment to tell you a bit more about the American College of Healthcare Executives. Carrie?
Thank you, Rick, and what a wonderful introduction. As you mentioned, my other day job is chair of the American College of Healthcare Executives. ACHE is an international professional society of more than 48,000 healthcare executives who lead hospitals, healthcare systems, and other healthcare organizations. Our mission is to advance our members in healthcare leadership excellence while offering the FACHE credential, signifying board certification in healthcare management. We further hold tight and are grounded in the steadfast commitment to the values of integrity, leadership, lifelong learning, diversity, and inclusion, all of which have been absolutely critical during this global pandemic. Like all great organizations, our power comes from the front lines, and we have a network of 77 local chapters who provide access to networking, education, and career development at the local level. Last year alone, ACHE delivered 25,000 hours of education to our members in such a critical time. So it's been a challenging time in healthcare, to say the least, and I'm proud of ACHE's work and innovation to support its members over the past 20 months. So great to be with you today. Back over to you, Rick.
Thanks, Carrie. Of course, the AHA and ACHE work very closely together. We at AHA focus on representing hospitals, systems, and other healthcare facilities as overall organizations, as institutions, while ACHE focuses on the development of the healthcare profession itself. And I often say that we're like brothers and sisters, with one exception: we don't fight with one another. And I also have to say that at ACHE, it's led by my good friend, Deb Bowen, who is their president and CEO, and the incoming president of the IHF, who I know will provide great leadership to the Federation along with Rod. Now let's hear from our panelists about their experiences and leadership challenges from the COVID-19 epidemic, or pandemic, I should say. Michael, we all know that New York experienced some very difficult challenges in the battle against COVID-19. Please tell us about your experience as a leader during that time and how your organization navigated these changes.
Well, thank Rick. I appreciate the opportunity. As everybody knows, COVID hit New York early on in 2020. And immediately, as an integrated healthcare system, our CEO, Dr. Steve Corin, convened the incident command structure, where we had all of the leaders of all the system hospitals together. And we met twice a day, morning and afternoon, to understand what was happening on each campus. Now, remember, we did not have a lot of data at that time. So we were figuring this out as we go. And we need a rapid decision making and resources deployment. And we used our data analytic team to do predictive modeling to understand the impact on the system in each of the hospitals that we had. And that allowed us to target our resources in different hotspots around the New York metropolitan area. Now, we had to rapidly expand our ICUs. We had to rapidly expand our monitored beds. We even had to open up a field hospital to add additional capacity to the healthcare system. And managing the resources, the physician, the providers with our, as you mentioned earlier, our medical school colleagues from Columbia and Cornell, as the three institutions worked critically and closely together to make sure we were providing the best possible care for all the patients in the New York metropolitan area. And then again, with our IT team, we rapidly expanded our telehealth capacity to ensure that those who didn't want to come into the hospital had the ability to talk to a doctor or a provider through their telehealth.
Carrie, how did your experience in California compare to Michael's?
I just have to say, it is so fitting that I follow Mike in this event, as I remember very vividly sitting on my front steps late at night, getting the full lowdown on all of his lessons learned. And it was April 14th of last year, as I kept the notes on my phone. And the title of those notes that we all keep on our phone, right? The title is "Oxygen Tanks Are Freezing."
Right.
Right. I'm incredibly proud of him, and I'm so lucky to know him. And also, Rick, just thank you for AHA's support also through the pandemic. Now on to KP. I am incredibly proud to share how Kaiser Permanente was able to stretch and flex to meet the healthcare needs of our members and our local communities through the pandemic. So I'm just going to boil it down to maybe two brief examples to highlight just the agility and the innovation, the expansion of testing capabilities and our telemedicine, as Michael also highlighted. So the Berkeley lab, when demand for COVID-19 testing far outpaced supply in early 2020, we moved quickly to significantly expand our testing capabilities. So the expansion included building $14 million. And this is in California, where construction is very challenging. We built it in less than 2 months and can now process over 20,000 tests a day. So great example of agility and fast thinking. The second one is virtual care. So early in the pandemic, with so many unknowns about the virus and shelter in place in effect, Kaiser Permanente was able to swiftly move to offering our members telehealth appointments as well as an alternative to in-person care. So from March to November of 2020, our KP physicians conducted nearly 3.7 million video visits compared to approximately only 100,000 for the entire year of 2019. Remarkable work around telehealth and video visits, just a terrific example of how we innovate on the fly. And I wanted to talk a little bit also about ACHE too. ACHE was also to innovate on the fly during the pandemic, acting quickly to share insights and understandings about the pandemic among membership. So it was early in the days. I spoke frequently to ACHE's CEO and the new IHF president, Deborah Bowen, and my colleagues around the board from all across the country, ACHE members, fellows. It was clear to me that healthcare leaders were eager to connect and learn how their peers were navigating patient care. So ACHE swiftly moved to respond to those needs. We held webinars with leading systems and CEOs, where thousands tuned in to learn from each other and from frontline insights and tactics. We developed entire issues in our member journals and our magazine dedicated to the pandemic response. We also created new member support resources with the benefit of universities and associations and other partners. We also ramped up, just like all the healthcare systems were ramping up virtual sessions, we at ACHE also ramped up our virtual sessions, delivered both nationally and locally. And a shining example was our all virtual 2021 Congress on Healthcare Leadership, which brought together over 9,000 leaders from various disciplines, sectors, and geographies. And thank you to IHF, who also joined us to deliver sessions on the evolving global health crisis. It was a true team sport.
You know, Mindy, some of that sounds a little familiar as chair of the association during the past year, where we were having weekly board meetings and almost monthly meetings with the entire membership, exposing them to government officials. But beyond that, can you share your story? How did St. Luke's navigate these challenges? And I know that in your part of the country, the challenges continue to be out there and you're continuing to face them.
Yeah, thank you. It's a pleasure to be with everybody today. And, you know, we had the advantage of learning from our colleagues on both coasts here in the heartland of the United States. And our first surge was not until the May-June timeframe of 2020. So by that time, we had already seen what was going on in New York, out on the West Coast, and really were able to learn from each other. And I think that was one of the lessons that I've learned from this is we are constant students in healthcare. And it was never more evident during the pandemic as, if not on a daily basis, certainly on a weekly basis as things change, we had the opportunity to take from each other and to do and evolve and take better care of our patients. At St. Luke's, we did much like Michael alluded to. We stood up our incident command system. We had 16 incident commands at all of our various entities, and then an overriding system incident command function so that the frontline teams could really look down and taking care of the patients, and the system command system could look up and focus on PPE so that we had enough PPE to keep our patients safe, keep our team members safe, keep our community safe. We worked hard on supply chain management, and I think that's a lesson for all of us in the United States. I think I certainly took supply chain for granted. I do no longer. And at one time during the pandemic, we had almost 500 items in our supply chain that we were inventorying twice a day, being sure that we could supplement where needed. The other thing that I want to mention is communication. In the crisis situation, transparent, honest, and frequent communication was key. As Michael alluded to at the beginning, we really didn't know the scope of this pandemic. We didn't know very much about COVID, and we had a lot of questions that were asked that we did not have answers to. And we found that communicating twice, 3 times a day in various ways, whether it's video, whether it was huddles in our entities, whether it was on our website, facts and policies and procedures and how to do things really made a difference for our organization. And that I don't know, or we don't know yet, was an okay answer, as long as it was followed by, we're following the science. As this evolved, we will communicate and be sure you have the most accurate and up-to-date information.
Thanks, Mindy. Let's make a pivot and let's talk about the intersection between leadership and trust. And of course, the best leaders know that they simply can't do it all alone. And for many of us, our COVID-19 response has been alluded to. It's really been a team effort, including everyone from the corner office to the back office to the boardroom. And whether a physician or a nurse, respiratory therapist, housekeeping staff, EMT crew, or a member of the cafeteria, each and every person truly made a difference. And, we at the AHA do a fair amount of polling in terms of measuring public trust and confidence that people have in hospitals and health systems. And our most recent research indicates a pretty high level of trust. And I think it's fair to say that for so many of us across the globe, hospitals were truly the most indispensable partner when it came to keeping patients and communities safe. So, Carrie, we know that workforce resiliency has been a big concern. Mentioned it earlier. How have you worked to foster a culture of trust and openness among your team?
It's such an important question. And it has been a remarkable 12 months for me since joining Kaiser Permanente last November. I joined in the thick of it. Being given the opportunity to not only lead Kaiser Permanente Northern California, but to do so during a global pandemic has truly been an awesome challenge for me. While there have been many and multiple learnings for me and my team leading through the pandemic, the greatest takeaway for me was the importance of rounding. Mindy mentioned this. The critical role of the KP mission and just how important it is to demonstrate leadership in the midst of a crisis. One of the first priorities when I joined KP was immediately to get out to all of the 21 medical centers and see firsthand and talk to the front lines on what was going well and what they needed support with. And this was in the height of, I think, which was the third COVID surge that we had. I also wanted to check in directly with the front lines to see how they were personally weathering the COVID surge of COVID-19 and to become familiar with and get a feel of the strong culture within KP and to start gaining trust and confidence of our local leaders and frontline team members. I always asked, how are you doing and how's your family doing? And sometimes I would hear fine or good. When their face and their body language told me that it was not the case at all. The stories I heard after when I asked, no, really, how are you doing? Were both heartbreaking and awe-inspiring. And it all came back down to the people of Kaiser Permanente in Northern California have a remarkable and unwavering commitment to the KP mission, which is to improve the lives of the communities it serves. The organization's collective commitment to the mission has played a critical role in my ability to successfully lead in Northern California during this crisis. It's why I joined KP in the first place. There was no question we were going to help communities with mass vaccination sites. There was no question that we were going to do pop-up clinics and vaccination sites in underserved areas and provide testing in underserved areas, and also going beyond that to provide support for food insecurity and homelessness. As the pandemic continues to change the world around us, our mission has never ceased to be the guiding light in keeping us in the fight to heal the sickest patients and to ensure that we get as many of our community members vaccinated as possible. Lastly, is that to highlight the importance of leadership, and this is a critical conversation for that. Understanding that getting as many people vaccinated as possible was and is the best way to end this pandemic. Kaiser Permanente led the way in its decision to mandate vaccinations for all of the organization, physicians, and employees back in August, which was closely followed by a similar mandate for all healthcare workers and by the state of California. I think our leadership in implementing a vaccine mandate shaped the vaccine mandate conversation at both the state and national level, ultimately helping to increase vaccination rates across the board. So regular rounding, remaining true to the KP mission, and understanding the importance of leadership in a very critical time fosters the culture of trust and truly the openness of the team.
And by the way, Kaiser also made another contribution in that one of their key physician executives has been working in the White House here in Washington, Bashir Kushah, as the vaccination coordinator. And we've enjoyed a very good and productive relationship with him in that role as well. Mindy, I'm sure you have a unique insight into this because you look at this through the lens of also being a physician. So what are the leadership skills that you think are necessary to set the tone for a culture that fosters trust?
I think just a couple of things. First, I want to start with the science. I think we started back in early 2020, really not knowing much about this novel coronavirus. But we as healthcare professionals knew that we knew how to take care of sick patients. We knew how to take care of respiratory disease, and we knew how to isolate patients and keep our staff and our patients safe. But the science has really been our guide throughout this pandemic, and that science has evolved. Sometimes that's led to confusion, but science is like that. It evolves as we know more. That is the scientific method. And I think where we sit today with vaccines that work, with monoclonal antibody treatments that help both in hospital and outpatient, and with the promise of more treatments and more research and more understanding of this virus really is a triumph of science. And I think always being in touch with that science has made a big difference for us at St. Luke's as we have navigated this pandemic. The other piece I might highlight is, in healthcare, and particularly those of us in healthcare that have large teaching programs, that have academic programs, we often like to plan. We have many committees, we study, we pilot, and if the first pilot doesn't work, we do a second. And I think it's very clear that COVID was not waiting for us to go about business as usual. And so all of us have had to learn how to lead with imperfect information, to make decisions with the information that we had, ready to adjust and pivot as we went along the way. And what's happened too is we've often brought together disparate groups of people who many times didn't talk very often. We came together, we made good decisions, and if we needed to change, we changed quickly. And I'm not surprised, but I'm very proud of the quality of the decisions that we've made and our ability to care for patients. And what we're doing now in 2021 to care for patients is very different than in those early days of 2020. And I think it shows in our outcome, and it shows in the way we as a learning culture have gone about our business.
Leading with imperfect information, that's something that I've heard you say in the past, and it's a real insight and perspective when it comes to dealing effectively and quickly in a crisis. Michael, here in the United States, we know New Yorkers always have an unusual perspective, and I think people across the globe realize that New Yorkers have a special perspective. But great insights come in threes. Anything to add from your end?
Sure. I think a lot of it you'll hear the same, which is authentic, visible leadership. And we had daily videos that went out to 47,000 of our employees every day about where are we with PPEs? Where are we with our care models? How many patients do we have in our system? What's coming into our emergency rooms? And that was important to get out. And on the local leadership at each site, we made sure that our leaders were walking around the building, talking to staff, as Carrie and Mindy had mentioned, right? The staff needed to see the leaders in the building very early on when we didn't understand this disease. Was it through contact spread? Was it airborne? Was it droplet? We didn't understand it, but they needed to see us as leaders in and around the building to make them feel safe. And when they felt safe, they start to trust. So when we changed how we were handling different things on a moment's notice, because as Mindy said, the science changed, the CDC or the Department of Health changed the regulations or the suggestions on how we should handle things, we had to change with that. We had to change how we're caring for patients based on the clinical condition of our patients. We put unique groups together. We had all the emergency room directors meeting every night at 8 o'clock. What's coming into your emergency room? What are you seeing there? How are you handling it? We had our hematologists doing the same thing, our ICU directors doing the same thing. And we were spreading the information around our system as quickly as we can. And as Mindy said, it came upon us quickly. From the first patient, about 3 weeks later, we were pretty full. And at our peak, we were seeing about 2,600 patients were in the hospital on a daily basis. So it came upon us very quickly. But I have to say, through ACHE and through AHA, right, the sharing of information around organizations and sharing of information from leaders around the country, I think that was helpful, learning from the experiences that were happening early in New York at the same time. And the other thing that was important to us was how we were handling and managing our staff. And as Carrie had mentioned, the mass vaccination center. We set one up and we had to do that. And we told our staff, bring your families. Let them come in. We will vaccinate our employees. We vaccinated the families. We vaccinated the community at large. But it gave them a sense of comfort that we were opening up vaccinations for their families to keep them safe. And I think it's the visible leadership, it's the transparent communication, it's the authentic communication, and it's answering questions. We might not have the answer at the time, but we'll get back to them. And we tell them, we're up front. We don't know exactly what's happening right now, but we're going to get back to you as we have more information. And every day, sharing of information was incredibly helpful in building of the trust.
Common theme here, key to leadership and building trust is being present. And I want to talk about the workforce a little bit more. But before I do that, I want to just throw something else out to get your reaction to this, because it was one of the common threads here in building trust. You know, one of the things that we experienced during this whole crisis over COVID is the fact that the science evolved and it changed. And new science and new clinical methods that improve care, it changed. How much did you all find yourselves having to play the role of an educator in making sure that not only the workers, but the public that you served understood that it wasn't black and white, that it was an evolving situation, and that it was okay that things had to be adjusted and changed based upon new learning? Anybody want to comment on that and the role that you had to play in that regard?
I would certainly start. This is now 20 months into the pandemic, and I cannot think of a single meeting that I have been to, either in the community, a board meeting in our system, or just a meeting at a totally different subject where I have not started by giving a COVID update. And the COVID update, you know, may have something to do with how many patients we have, but basically has been the opportunity to educate, to talk about how treatment is evolving, to talk about the differences in vaccines, to listen to vaccine hesitancy stories, to talk about what we know and what we don't know, and to really talk about the scientific method and how the evolution in our treatment is a good thing. And so I've spent a lot of time educating, and I think it's been incumbent upon all of us in healthcare to really fulfill that role, because as everyone on this panel knows, the amount of disinformation and misinformation out in the public has just grown exponentially over the course of the pandemic thus far. So it's been a regular feature of what I have done on a multi-time-a-day basis.
Yeah, I would just completely echo everything that Mindy just highlighted. There isn't a conversation, both professionally and personally, that doesn't revolve around COVID, boosters, horse vaccines, lots of interesting perspectives, and it highlights the opportunity that we all have going forward beyond COVID. And once we get through this pandemic, which we will, just the power of clear, consistent communication and our support of science, and the power of ensuring that you mentioned, Rick, earlier in the conversation around our diverse communities, and understanding that one form of communication is not going to be received the same by every individual that we serve. So ensuring that our communication is also equitable and is coming from that trusted source. And sometimes that's the physician, sometimes it's a clergy member, sometimes it's your own family member. So I think it has highlighted just the power of consistent communication, both now and going forward, not just to our teams, but for our communities.
Yeah, I have to agree with what both Mindy and Carrie said. I don't think I've been anywhere in the last 20 months where we didn't start with a COVID update. How many are in the community? How people are getting vaccinated, about the monoclonal antibody treatments, whatever the case may be, it is a start. But I think what's important is that the community learn that healthcare systems are trusted partners for the community, and that we're going to be there for them, whatever the crisis is, whether it is a COVID crisis, whether it is a hurricane, whether it's a storm, loss of power, that the healthcare systems and hospitals are going to be there for them. And I think the public also learned that the healthcare system is part of the infrastructure of America, that we are there for them. And whether it's us as executives getting out and talking to people in different meetings and forums that we are in, or getting some of our doctors into some of the communities that are hesitant and let them talk about why they need to get vaccinated. All important things, but the message, you can't over communicate the message and what we need to do, and we do it in a variety of different forums.
Thanks. And one of the things that came through in this conversation that we've learned as well is when it comes to sending the message, I think Carrie mentioned it, trusted messengers are what's so important. And certainly physicians and nurses are trusted messengers. Church leaders are trusted messengers. It all depends upon the specific community that you're communicating with. And, one of the fallacies is to think, and we see this sometimes here in America, when celebrities and athletes are rolled out, they're not necessarily the trusted, messengers. It's really the people that are at the local community level that are the trusted messengers, or the clinical ambassadors, if you will. So hospital leaders across the U.S., they say, when I ask them what their priorities are these days, they say, priority number 1, workforce, priority number 2, workforce, priority number 3, workforce. And certainly the pandemic has tested the resilience of our healthcare workforce like never before, sometimes resulting in certain folks leaving the professions altogether. And as we know, without a resilient health force, we cannot exist. Our entire healthcare system breaks down. It's as simple as that. And that's why I know I speak for everyone when I say that there is no higher priority than ensuring that we care for the caregiver, and that we make our environment, our working environment, safe, and that we foster the ability for individuals to have joy in their work. And this has magnified the need to create resources and provide tools to ease stress and anxiety and increase a sense of well-being for our caregivers to enable them to focus on their mission of providing healing care. Here in the United States, the AHA continues to press for additional resources, additional regulatory flexibility to increase the capacity of caregivers, but also to allow health professionals to practice to the top of their license, to fulfill their full potential. So Dr. Estes, under your leadership, St. Luke's is known for putting clinical excellence and compassion at the forefront of patient care. How have you worked to support your providers during these challenging times?
Well, thanks, Rick. And workforce. It is top of mind all the time. And let me just level set a little bit. workforce issues in healthcare and resiliency and burnout issues in healthcare in the United States predated the pandemic. We were already suffering from burnout and stress at really alarming rates. Just to give a couple of statistics, pre-COVID, 8% of the general population in the US had PTSD. In our nursing colleagues, it was 22%. For nurses in-house today, it's 62%. As we navigate this pandemic, and nearly 60% of physicians are feeling burned out. And so, the root of all of this really is in the care delivery system. And we have to find the solution by changing the system, not the person. And that really is, I think, our role as leaders. And so it has really brought to the top of mind at St. Luke's the critical importance of retention, of keeping the employees that we have. We all certainly want to recruit more because we need more. But, by keeping the team we have, we create better efficiencies, we reduce waste, we improve care, and we build on the culture that Carrie talked about early on about being mission driven and having patients at the center of what we do. So we've done a number of things. One is to ensure that our wages are competitive, to recognize that our folks need more time off, that we have done some things like thank you bonuses to just have our employees recognize that we understand the sacrifices that they've made. At the same time, we're really thinking hard about reskilling our workforce, the numbers of hands and types of hands that we put around our patients, both COVID and non-COVID. And, I think there's a real reason for some of this rethinking. We have to change our care model. We have a short workforce for lack of training. There's an awful lot of competition for our frontline workers. And I can't remember if it was who on this panel said, we have a whole host of folks who are frontline caregivers, from environmental service workers to our nutrition folks, to our patient transporters, our medical assistants, our nursing assistants, and we compete with non-healthcare entities for those workers. And so what we really have to do is to create a compelling reason to work for a higher purpose, which is what we are doing here in healthcare. It's an investment in people, it's a willingness to listen, and it's really responding and being really creative around the needs of your specific workforce. So we are evolving. I think our care sites will evolve, but this is not a short-term fix in the U.S. healthcare system in terms of our workforce shortages. So I think we will, again, as a collective, come together, and we had a long conversation in our most recent AHA Executive Committee meeting about what are the creative ways we can learn from each other in the field as we tackle this.
Thanks, Mindy. Michael, how are you continuing to engage your workforce during this ongoing crisis, especially when New York providers have been dealing with this pandemic for so long?
It's been difficult, but I think Mindy said we're really focusing on making sure that we retain the employees that we have, right? And letting them know what our mission is. We reinforce the mission, we reinforce the vision and the values of our organization for everything we do. And every employee who works for the organization has to understand what the work that they do impacts the care of the patient at the bedside, whether they're a direct patient care provider or not. They have an important part of doing that. And we've spent a lot of time developing new programs, adding new space to the building so that there's quiet time for staff to take some time during their shift to go in and recovery with soft music and dimmed lights so they can relax a little bit. It's about the self-care we have. And we got to recognize, as Carrie and Mindy mentioned earlier, to recognize the burnout in our employees when we see it, and how do we pull them aside and get them some help that they need. We developed the NYP COPE, which is an anonymous program for staff to call and to deal with emotional or burnout issues on a confidential basis. We have other well-being support services. We provided food and transportation to employees to get to and from work. We provided lodging, we extended child care for employees, and we created a hardship fund for those employees who are struggling financially because one spouse or the other might have lost a job and has been very difficult then. So we work really hard in trying to maintain the employees we have, but as Mindy said, we got to be competitive in our environment to be able to recruit new employees in. And then we get them in and try to promote them and let people understand that we're an organization that you can grow and expand and work to the top of your license in as an organization. But we're also partnering with many of our local colleges to do clinical rotations through our organization, because when you get them here and they see how focused we are on caring for the patient, it's somewhere they get comfortable with and then they want to come and join.
All good ideas. Carrie, what's the secret sauce at Kaiser for ensuring workforce resilience?
Great. Well, I love that all three of us are starting with mission. I think it's fundamentally ensuring that the work that you do every day is for the betterment of society and taking care of people. That's fundamental. As many of you know, Thrive is also a very important part of Kaiser Permanente brand and how we talk about ourselves to consumers. I'm really incredibly proud to say that we work just as hard to ensure that we reflect the brand on the inside of the organization as well. We understand that we can't bring our best selves to work if we can't care for ourselves individually. I always like to say you can't be your best selves at work if you don't take care of yourself personally at home and with your family and live your best life there. And it's been and continues to be just a critical part of our prioritization, well-being of the individuals that we're privileged to serve. We have great things like the Calm app that's offered to all of our members and our employees. We have those meditation rooms. So glad to see that may be the new norm for all of us. I would say the other piece that I think is incredibly important that I'm not is, and Mindy highlighted this, which is a change of the culture at the top. I think it's critical that we model self-care at the highest levels of the organization and be the best role models. It's been a huge takeaway for me. I probably wasn't the best role model of taking care of yourself before the pandemic, but I'm happy to say, it's about a constant conversation, taking a break to get outside, taking time off, the importance of it, and celebrating when you take time off of work, and not giving this hero-like response to when people are saying they worked really late last night or they worked 10 or 12 hours yesterday. Changing the conversation has been incredibly critical, and also making it okay to speak up when you're not at 100% and creating this environment that it's okay to not be 100%. We're never at 100%, all of us, any of us, every single day. So it's okay to be at 30 to 50 today. That's when you can tell your colleagues that I'm not quite where I need to be yet. So let's help each other through that. The other thing I would say that creates the secret sauce within Kaiser Permanente, and this is going to be true for Mike and Melinda, as well as collaboration and teamwork. Throughout the pandemic, our employees have truly been in this fight to keep our patients and members safe and healthier together. I talked to one of our team members in the ICU during the forced surge of COVID. He was highlighted to me by a nurse leader as someone who was amazing, thoughtful, a great team player. He had also just recently lost his house in the Caldor fire in Tahoe. So we hugged and we cried, and I asked him, kind of surprised that he was into work that day. I asked him, why are you here? Why are you here today? What drew you in? He says, I love my team. They are my family. I could not get through any of this without them. And so to create a culture that people feel not just that it's their profession, but it's who they are at the root, I think is how that we continue to foster resilience in our workforce, how it creates a beacon and a magnet for people to come and want to work and to join a fantastic team. I'm just humbled to be a leader of such amazing teams who have been through this horrific time. So proud of them. And we have we've always had heroes. Just now everybody gets to see the cape.
We have a few minutes left here. Let's do a quick lightning round, and let's ask each of you to respond. Anything we left out that you want to share? Mindy, you want to start?
Sure. Let me just highlight the importance of technology during this pandemic. And certainly as we talk about workforce, our ability to use the technology we have, artificial intelligence, is a great example. Our apps that help us recognize sepsis more earlier and intervene sooner, to virtual care, to remote monitoring, to being able to send people home with pulse oximeters and guidelines and have them, call us if things start to change, to also doing some innovative things. We opened a virtual a unit at our St. Luke's East Hospital. Every room, we built it during the pandemic, has a 50-inch computer screen. We have a virtual charge nurse who can camera into any room, who can do a lot of the administrative work, the education work, answer questions, and free up the caregivers who are on this unit to provide the hands-on care that's needed. And so it's been so successful from a quality and satisfaction perspective that we're going to expand that. So I think the importance of using technology that we have and being creative about how we deploy its workforce, its leadership, and it's also crisis management.
Michael, any last thoughts?
Sure. Technology is one of those, but I would have to say health equity and the focus on getting out into those communities that we are seeing disparate care. And our organization, New York Presbyterian, has spent a lot of time and effort making sure that we're expanding into different communities to try and narrow the gap on the equities, whether that is those who are getting COVID, whether that's who need the vaccine, or whether that's just healthcare in general. So we're spending a lot of time and effort making sure we get to all different parts of the New York metropolitan area to improve the health status of all the different communities. And our Dalio Center has been a key part of that.
Carrie, you want to get in the last word?
Yeah, well, I don't know about the last word, but I'll just piggyback off of both what Mindy and Michael said. I think technology and also the commitment to equity and looking at the care that we provide through the lens of equity. And Kaiser's known for prevention. So I'm really excited and just awe-inspired by the focus now of all of the quality measures that we've ever done, all the care pathways that we've done, is now taking it through the lens of equity, which is really going to, I think, revolutionize how we've truly provided care in the past. So very excited about taking those bright, shining moments that happen out of a horrific event and focusing on the good and taking that forward into the future. Continue to innovate.
For sure. We all hope to see that we use this unfortunate situation as an opportunity to improve the healthcare system for all. Thank you all so much for sharing your perspectives and insights. That was a great conversation. Thank you for all of the leadership that you provide. You are all healthcare heroes. And our hope is that today's panel will help us all better meet our common challenges. A few months back, we were optimistic that we were turning the corner in the battle against COVID here in the United States, but that's been replaced by a hard reality that, like many of you, we're going to have to coexist with COVID for the foreseeable future. And the pandemic continues to challenge the health of all of our nations and our hospitals' ability to transform care for the future. And the pandemic continues to directly impact our caregivers, as you all heard, and those who serve with compassion, commitment, and courage. While every healthcare system may be different across the globe, our mission of caring for the sick and the injured and keeping people healthy, that remains the same. While every healthcare organization and system across the globe may be different, we all share the same goal in providing the best care to every patient every day in every way. And the one thing that we all share in common is that iconic symbol, that H. It is a symbol of caring and compassion. It is a symbol of safety and security. And it is a sign that says that the people who work there uphold the highest professional standards in taking care of the patients and communities they serve. The American Hospital Association really values the work of the IHF, particularly the fellowship among the leaders of the associations themselves. And while we feel as if we have a lot to share, we also know we have a lot to learn, and that's why the IHF is so important. Thanks for joining us for this panel discussion. It's been an honor and privilege for me to moderate this session and be part of this year's World Health Congress. I'm now going to actually toss it back to Barcelona for Mindy and Carrie to continue this discussion, where they will welcome your questions and comments. Mindy?
And I'll kick it off as we get settled down. There's a couple of questions that have come in already. So the first question is really about leveraging a broader dialogue between hospitals and health systems, and indeed going beyond senior leaders. So I think the question is for both Dr. Estes and Carrie Pleats to really talk through what are the frameworks to keep a broader dialogue going and allow people to better communicate.
You know, it is at the center of everything we do, and it is also one of the most difficult things that we do. Especially, you know, in a system like ours, which is a little smaller than what Carrie is talking about, scattered all over Northern California, is just to be able to communicate not only from the top, but also to be able to understand what the people who are doing the real work are experiencing. And so there are a whole host of ways that we've always done, but I think we have honed those a bit during the pandemic. One is just regular, sometimes daily communication from me or from some of my senior leadership team on video throughout the health system, huddling with a whole variety of people throughout the health system, in encouraging all of our directors, managers to really take the temperature of what is going on in the front lines on a daily basis. And one of the things that I have been so struck by during the pandemic is the leadership at our front lines. People who have really, quite frankly, been invisible to me in the organization, who, when given a task, have showed extraordinary leadership, extraordinary creativity, and collaboration. And that has been replicated day after day after day in the St. Luke's health system. And, you know, what has been, I've been searching for, and it's been incumbent upon those of us in leadership, is to not lose that and to remember who those people are. They are the leaders of our future, and they are leaders that have been quietly leading at their local level, but who in a time of crisis have really shown that they have extraordinary ability. So it has evolved as the pandemic has evolved. And, you know, Rick talked about, and Carrie talked about good things coming out of the pandemic. I often say you're making lemonade out of lemons. And that certainly is one of the things that has really struck me, is the depth of leadership expertise we have throughout our 12,000 employees.
That was fantastic. I don't know if I have too much to add to that, other than just to underline, you know, we've always talked about patient safety and the criticality of communication at all times, and how you reduce patient harm through strong communication, and the key root cause of patient harm is usually a communication breakdown. So I saw that those organizations that had that strong patient safety culture of communication really thrived during the pandemic and got even better. And those organizations, and because I have 21 hospitals, I got to see a little bit of a variation. those that didn't have as strong of a communication link from the front lines, inclusive, interdisciplinary across the board, had more challenges with uptake and resistance and over questions, and also had a little bit of a dip in patient safety. So just had to underline this critical comment that Mindy had around communication from the front lines to the top and the top back down. And for Kaiser Permanente, beyond Northern California, this was communicating to people in Washington, D.C. This was communicating to our other 8 different regions across the country. So the key thing will be to ensure that we don't lose. There's been questions about, well, do we still need to do all of these video sessions? And I think we need to ask ourselves before we stop any of the communication that we put into place during a crisis, should we continue them? What was the benefit? And not immediately jump to, we should go back to how we were communicating before the pandemic. I think that would be a very strong disservice.
I think as a follow-up to that, can you express how you think health system to health system could better continue a broader communication at a national level to have more conduits for, just understanding of what's going on is another follow-up to that same question.
I would say that's a great follow-up. The competitive nature, COVID equalized us all to an extent. So this competitive situation where, and now that I'm not in Atlanta anymore, but we had significant competition where people would, be nice and shake hands at the hospital association meetings, and then would go back to their corners and fight vigorously for within the marketplace. But when it came to COVID, that's true in both Northern California and in Atlanta, because I was in both markets during the time, it didn't matter, because it was all about the patients. It was all about the community. What are you learning? What are you seeing? How can we do this differently? And actually, the communication with local governments, local public hospitals, state agencies, federal government, it was a leveling of the playing field, and the communication opened up quite a bit. The question is again, how do we build upon that, knowing that this, unfortunately, is probably not going to be the last pandemic that we go through, and there is so much good that came out of, and for the betterment of our communities and our patients, by having those more open lines of communication.
I might just add, I think it is a bit sad to say that one thing that came from COVID is to remind all of us in every hospital and health system in the United States, and I suspect across the world, why we do what we do. We are there to take the best care of patients that we possibly can. We are there to care for them at their most vulnerable. They tell us things they will tell no one else, and it is a privilege to do that. And I think that privilege came front and center. And so this meeting is an example of how we communicate hospital to hospital, country to country. In my work with the American Hospital Association as chair in 2020, we really reached out to a broad range of institutions across the United States. And what we did at AHA was, we have over 5,000 members, but we said on our all-member calls, whether you are a member or not, please come join us. Please come listen to the information. Please come learn from each other. And so I think we are beginning to lay that groundwork that says we can, and in some cases it's easier than others, to put that competitive piece aside when we realize that at our very basic, what are we here for? And I think in some respects, as challenging as COVID has been, to paraphrase Winston Churchill, I think it was our finest hour. We came together and we did the best we could, and it was excellent under extraordinarily difficult circumstances.
Here's another question with regard to workforce. And I think, Dr. Estes, you mentioned, using technology as an opportunity and agility as well. So what are you both doing to essentially build that next generation of leadership that would help give sustainability and continuity of care in the future, knowing that there's so many issues you're experiencing with workforce and burnout and potential for attrition?
Yeah, so I would say, it was, it's, workforce has been, and Mindy, I think you mentioned this in your comments, workforce constraints, physician availability, nursing availability was an issue before COVID, and COVID just exacerbated the situation to a very broad extent. One of the things that we didn't have in place at Kaiser Permanente, which I found very intriguing, was we didn't have a nursing residency program, which is surprising. I have 80,000 employees just in Northern California, and a vast majority of them are clinicians. And we weren't growing our own. We started the Bernard Tyson Medical School, but we didn't have a nursing residency program. We started it during the pandemic. We opened up to the initial 100 cohort slots. We had 1,000 applicants for 100 slots. We just opened up 250 more. We had 1,500 applicants. So it's really, okay, that's just medical surgical nursing residency programs. Why not have that for every single profession within Kaiser Permanente? And there's the possibility of doing that. I think the other thing just to mention on the workforce is we in healthcare, and perhaps this is just within American healthcare, I can say, because I've been in a few different systems in America. I'm sure it's not in any other healthcare system. Is that some of our processes are not very efficient and not fast. And if you think at how many workflows, how many processes, how many policies would we put into place that add a burden to our clinicians. How much work do physicians do that truly are not at the top of their license? How many times do we have nurses show up to a shift and they have to look for something, or they have to fill out potentially paperwork, or have to do additional clicks into the system, into the electronic health record, that are really not value add to the patient? I think we're all in this performance improvement cycle journey, but that has to be a top priority to reduce the amount of work that is preventing our phenomenal workforce from working at the top of their license. And I think and part of that's AI. We have artificial intelligence that can analyze lab results. We have artificial intelligence that can look at 50 different indicators within the electronic health record and tell you if there is going to be a potential episode or an increase in severity of a patient. And yet, do we have that systemized across our country? And we don't. So I think that is the next evolution as we work to get more people in, educate the future, create an even better environment for people to work. It's how do we change the work? How do we help and get their voices into the changing of the work? They have the best ideas.
I might just add two things. One is we talk about innovation in healthcare all the time, and we talk about workforce innovation in particular because we are all focused on workforce. Most innovation is not transformational. It's not up here. Most innovation is iterative. It's down here. And when we ask the people who actually do the work, it is amazing that they can tell us right away that these 5 extra clicks in the electronic record are a burden and really don't add anything, that how many people touch the patient that may not add value. And so once we begin to do that and take a hard look at our processes, as Carrie mentioned, that is one piece of it. The second piece is this notion of technology, particularly artificial intelligence. And there is a great fear. Healthcare is both science, but it's both an art. Medicine is a science and an art. And oh my gosh, this is cookbook medicine. You're going to tell me, some computer is going to tell me how to take the best care of my patient, or this computer is going to take my job. And it really is overcoming that barrier that these are additional tools to help you do your job better. And, I had a boss one time who talked about purposeful redundancy, that you have to say it over and over and over again till all of a sudden who you're talking to, it becomes their idea. And so I think it is overcoming this mistrust of the digital and artificial intelligence tools that we have available to us.
Anything to add, Carrie? Were you about to say something?
No, I completely agree. The digital mistrust, and I think it's fact that adults have to hear things 14 times before it truly sinks in.
One other question. Oh, great.
Thank you both. This has been fascinating. Carrie, you kind of touched on this, but hearing all of you talk about the consistency and the importance of recruitment, retention, resiliency. And Carrie, you just talked a bit about redesigning some of the processes within our care model to be more efficient, to help the workforce in all three of those things. Yeah. But I wonder, are any of your organizations looking at a more drastic change in our care model? Right, so as nursing is in a huge demand, I think there were 3,000 open contract positions pre-pandemic, and I think there's 60,000 today. That gap is not going to close quickly through only retention and recruitment. Are y'all looking at more drastic changes to the care models in your organizations?
Do you want to go first?
Sure, I'm happy to go first. The short answer is yes, and it is very easy to say and very difficult to do. Just to give you one example, I believe that home will be the epicenter in, I don't know if it's 5 years or 10 years. We've seen that through virtual visits, through telehealth, but it's home monitoring, it's home dialysis, and we are working hard on hospital at home. The notion that it's essentially just another unit at the hospital, but we are caring for you virtually at home. And, as all of the folks in the audience who have a clinical background know, there are a whole host of diagnoses, from pneumonia to heart failure to cellulitis, asthma, that could be cared for at home. And so that's one that we are working on, and we believe that beginning in the May-June timeframe, we'll have about 14 patients a day in our hospital at home program. And if I look and I believe the projections, and I'm not sure yet I do, that ultimately could be 50 patients a day. And if you think about that, many of us, if we had the opportunity to receive hospital care at home, and I think of particularly my elderly father before his death, did not want to go back to the hospital one more time for heart failure care, and said, if they can take care of me at home, I'll be happy. So I think that's just one way of trying to decant the acute care hospital by using, I think, home as the epicenter.
And Mindy, fully support the acute care at home model. We have been piloting that. Sometimes our pilots in KP go a little long. I think we've been piloting it since 2019. The
pandemic.
We have over, the pandemic, COVID. But we have over 50 now and are expanding it. So we're full supporters of acute care at home. And to speak to what Mindy just said, it's the cultural adoption too, because the National Nurses Union within the United States, that's fearful that this may detract or take away their membership on the inpatient side. And if you look at every statistic, we're still going to need nurses in the field, and we're still going to need nurses in the acute care setting. Our population is still growing, and they're still aging. So the statistics are support. We're still going to need them. We're just going to need them in multiple settings, whereas before it might just have been in the inpatient setting. Also speak to pharmacy as well. So, the days of coming in to get your prescription, and this, again, might just be a United States phenomenon, but we force our patients to come to a pharmacy when, in fact, everything could be mail ordered to an extent. And when we shifted, now 50% of our members receive all of their pharmaceuticals at home. So all of their pharmaceutical consults are either via video visit or via phone or chat feature as well. why is it just 50%? The satisfaction rate of our 50% is 98.7%. For those who come in and wait in line or in queue, you can imagine the satisfaction rate is slightly lower. So why is it not 75%? So that changes the model of care delivery for the pharmacists. They're still working at the top of their license, but in a different way. And we have some that are on the early adoption side and believe that that's fantastic. That's exactly where they want to work. And frankly, many of them are working from home. Versus driving into the pharmacy every single day. And so you just start to think about all the innovations, the capital, the operating expense, the quality of life in the workforce, and the type of individuals who may be drawn more to a pharmacy at home than a pharmacy in the office. Those are just two brief examples, and they're endless. So it's a great question.
There's a follow-up to that, just in terms of like healthcare at home, hospital at home. Monitoring things like hypertension, how do you get better compliance in a home environment? Are you all experimenting in any way with your design or systems in that capacity?
We've been nonstop experimenting and determining what we have a wide variety of physicians that are involved. And so with that, we've got some that are conservative and some that are don't want to say bleeding edge. So it'd be very inappropriate for a physician to be a bleeding edge physician. But really pushing the envelope. And so that's why we've had our research team, our analytics team, the data team researching every single patient that's gone in, looking at the results, looking at both and longitudinal results after post-discharge from acute care at home. And so I would say, just like we talked about science earlier, performance improvement requires change, requires iterations, and we've been through multiple iterations. And so the acute care at home today that's successful is going to be much different, I think, in the acute care at home a year, 2 years, 3 years from now. I also think imaging technology, the wearable devices that we have today are phenomenal. And if you think about the first iPhone came out, who knows that in the audience? How long ago did the first iPhone come out? 2007? You think about that. And that wasn't that long ago. And what are we on, iPhone 50,000 at this point in time? You can just imagine where the imaging and all the diagnostic devices are going to go. Bless you.
Bless you.
I would just add, I think it's certainly a hospital at home setting, but the sophistication of our monitoring lends itself to at-home monitoring as an outpatient or just as part of your life. I can tell you my heart rate right now on my watch here, my iWatch. And so I think the sophistication of that monitoring is going to continue to increase. And what we don't talk about and why we're on iPhone 50,000 is the fact that, we get immediate feedback. And so if I'm monitoring my heart rate or I'm monitoring my blood pressure or I'm monitoring my blood sugar or ultimately my hemoglobin A1C, clearly I get instant feedback on what's going on. And many of us and it takes education and repeated education for our patients to understand why that's so important and to send it on to the physician, to the nurse practitioner, so we can intervene before you need hospital at home.
Mm-hmm. Perfect. Thank you. Thank you for the amazing presentation. One of the themes that I hear about, and we've been hearing really all week so far, is about the innovation that we've had, particularly from a technological standpoint, whether it be AI, predictive analytics, expanding our sort of IT infrastructure. As an industry, we haven't been historically phenomenal at translating introduction of technological innovation into cost reduction and sustainability. Mm-hmm. I'm curious to get your perspective, as we're overwhelmingly talking about introduction of new technology. How do we take the innovation that's been gained over the last couple of years and really translate that into not only technological innovation, but also cost sustainability?
I'm going to channel my inner Yazdi, who is a member of our team who just joined Kaiser Permanente. He's phenomenal. He comes to us from Walmart. And he did the shared services integration for all of Walmart. And he fundamentally believes that every single technological advance and every type of modification in a shared service function should be cost neutral. And he can prove that out. And so I think part of this is mindset and how you approach and what you prioritize. I think there are many, I think that we have so many possibilities of technological advances that are, and when I say cost reduction, I'm saying from the global taking waste out of the system. That could be keeping people at home, that keeping people thriving, increasing their satisfaction with what's going on, as well as reducing the cost burden to society as a whole, because you're providing care that's inevitably not necessary. There's so many different line items for that. If we just focused on those, that's going to keep us busy for the next decade. There are going to be technological advances that inherently, whether that's a new MRI or new CT or, those types of fun things going on. But just as many, as Yazdi always says, nothing that you should do or implement should be a cost add at this point in time. It's just a matter of perspective. So I'll give you Yazdi's number if you're interested. Just kidding.
I would just say, I think it's enlightening to us as an industry when we bring folks onto our team and people into the tent, if you will, who come from a Walmart, or who come from Google, or who come from, in our world in Kansas City, Garmin, Cerner, the different mindset that they bring, and they take a look at what we do and sort of shake their head.
I would say the other thing that Yazdi mentioned is that in performance improvement, sometimes when you think about a medical center, we'll do improvement in the ED, we'll do improvement in the OR, we'll do improvement in a clinic, or we'll do improvement in the lab. And how many times do we really step back and look at the whole ecosystem truly and focus around what outcome do we really want? And I think that when you take a step, my immediate response to that was, I do that every day, Yazdi. Of course we do. And he said, do you really? And I took a step back and, I had to be self-reflective, saying, well, of all of the performance improvement projects that we have going on, the majority are departmental and not always looking at that cross-functional stance. And that's where the magic is.
I think we're almost at time, but one last question. I know you both had to deal with numerous concurrent crises over the last 18 months, wildfires, COVID, tornadoes. Is there any last final thought that you would just impart to other leaders like yourself or aspiring leaders?
Go ahead, Minnie.
Well, I think I said it earlier. I think several things. One is this has been a triumph of science. And medicine at its heart is science, and we need to celebrate that science. I think we also learned that, as a global healthcare community, we are there to do the right things for our patients and to provide the best care we can. And there was really there are tremendous examples across the world in terms of things that have happened, and that we are a learning community, and we learned from each other, and where we are today is different than where we were before. And again, I just come back to Churchill. I think with all of its struggles, it really has been our finest hour.
So I'll stick with another quote here too is, there's always Franklin Delano Roosevelt said, the only thing to fear is fear itself. But the rest of the quote is essentially, don't let fear prevent you from acting. And I think we've shown that through significant fear, the individuals who stood up and went to battle was healthcare. I mean, I guess we all did, but the doctors, the nurses, and PPE, frontline, creation of vaccines by our scientists. We showed the power of all coming together as a healthcare industry, and I know IHF has been doing this since 1929. I never looked at Italy's vaccination rates before the pandemic. I didn't pay attention to Germany's uptake. I didn't pay attention to what strain the UK was going through. I think I had this epiphany of truly understanding how small the world truly is and how we all need each other. So my key takeaway is don't let fear keep you from inaction, and understand you have support across the entire globe working to solve the same problems, because we all want to be here for our patients and our communities. So I'm so thankful that you are all here, and I'm so thankful to be a part of the group.
Yeah, great words. Thank you, Carrie Owen-Pleats and Dr. Melinda Estes, and thank you all for listening. And that's going to conclude today's session.
Great. Be safe. Be well.